Well,
Ahead.
good evening, everyone. And first of all, it's an honor and privilege to represent the Delta again and AKAs with the awesome awareness campaign effort. Kudos. I truly enjoyed my first time with y'all last year in person, and hopefully we can do the same next year. Um, and we're wearing red today in honor of not only those who've had and been survivors of cardiovascular disease, but also this year I dedicated to those who have lost either a loved one or a close family member during COVID, related or non-related to the heart. So the topic that I'm going to talk about today has to do with the general theme. What is cardiovascular disease? Why is that important? How does it apply to COVID? And what are some of the things that we can implement in our daily lives to not only mitigate the risk, but also to be aggressive and be more informed and transformed? So, as I always tell people, cardiovascular disease has been the number one killer, not only in the United States, but worldwide for a long time. It kills about 700,000 to 800,000 people a year. One in four deaths every day are due to cardiovascular disease. One in three women on this Zoom call will die from a cardiovascular event, unfortunately. And those who are disproportionately affected are those who live in low to middle income households, predominantly those who live in low socioeconomic status and also those who are in communities of color. Now, what is cardiovascular disease? It's very important that we put a definition to it because everyone always thinks of the heart and say, well, heart disease equals cardiovascular disease. That's not the case. We're missing the boat. So I need to define that so that I can carry an informed conversation with y'all. Cardiovascular disease comprises of a bunch of diseases, all right? Namely, if you've ever had plaque buildup in your heart or in your blood vessels, right? Then that is definitely due to coronary artery disease. If you suffered a heart attack, that is a byproduct of coronary artery disease. If you've had a stroke or TIA, transient ischemic attack, if you've had peripheral artery disease or poor circulation in your lower extremities, if you've been told you had a clot in your lungs and called pulmonary embolism, if you've been told you've had an irregular heart rhythm or called an arrhythmia, or if you've had palpitations where you had to go see a electrical version of Dr. Fakurede, who's an electrophysiologist, if you've had issues with heart failure, and if you've had congenital heart disease, and lastly, if you've had valve problems with your heart, all those items I just listed off comprise of cardiovascular disease. So it's very important that you understand that the risk factors for cardiovascular disease also are noteworthy because they also disproportionately affect most of the people on this call, namely a family history of cardiovascular disease. Two, if you've ever had diabetes or pre-diabetes or borderline sugar, right? If you've been told that you've had high blood pressure, high cholesterol, if you've been told that you have um, obesity or you're overweight based on exams, and also if you've been told that you have smoking or nicotine exposure, so you dip, you chew, you vape, those are all risk factors. So if you live a sedentary lifestyle, you're not exercising, and you've had all those risk factors, that constitutes cardiovascular disease. Now, how does cardiovascular disease affect this current pandemic? Um, what's sobering and what we knew before the pandemic is that social determinants of health is the number one cause of health disparities in America. And for lay people, what social determinants of health means is that there are certain factors out of health access or health coverage that determine if you live or if you die. And that has to do with how stable you are from an economic standpoint. Can you afford an income to get by every day or every year? Can you afford those medical bills? Is there an equity, meaning are you on the same footing as other people in your community or other people who don't look like you? Two is transportation and also physical and environmental access. So how's the transportation to care? How's the transportation to work? How is your environment in terms of the ability to go out and safely walk or do the exercise regimen that you're told by providers to undergo? And three is, your access to quality foods or food deserts, which is the opposite. How prevalent are they in these communities? You also have to look at the educational status of the community, not only the literacy level, but how well geared are our educational systems to not only deal with a pandemic, but before a pandemic, to be able to teach our kids what they need to learn and take them to a level whereby they can attain a level of education so that when they go for health assessments or healthcare, they understand what's being disseminated or told to them by those primary care or specialist providers. And then we look at the social context of what we live, community engagement, we look at discrimination, biases, and then we look at, cognitive dissonance, what's being spread out in the community that doesn't reflect with the true signs. And then lastly, we look at health coverage, access to care versus access to quality care, a big difference, especially in rural areas. How many people can afford healthcare? Did your state take on, the Medicaid expansion? How well, competent, both technically, culturally, and also interpersonally competent are your providers? Those are things that determine health outcomes, and a combination of all these things are called social determinants of health. So when you look at the COVID-19 and you look at just the drastic numbers, I jotted out some of them, right? So communities of color were 3 times more likely to be infected with COVID-19 in Black counties compared to our white counterparts. But the most sobering data is we're 6 times more likely to die from COVID in our minority counties. Is this shocking? No, because heart attack rates, amputation rates, and death rates have always been higher in such counties. Every 40 seconds, a human being dies from a cardiovascular event. Every 3 minutes, a person dies from a stroke. Every 30 seconds, a person gets amputated from diabetes and peripheral arterial disease. These are sobering, but these disproportionately affect communities of color. And so when we talk about COVID and how the heart is affected, you have to look at 4 theories. And these are theories that you all have to understand. When a patient has COVID is primarily a lung infection, a pulmonary infection. But what happens is that infection creates a couple of things and triggers a cascade. And that cascade are the following. One, there's a supply and demand issue that actually comes up when it comes to the sister of the lung, which is the heart. The heart gets oxygenated blood from the lungs. So if your lung is affected and it's undergoing a stress, the heart in turn will become stressed and not get enough oxygen supply, not only to muscles, but to other organs that it needs to supply. Secondly, the inflammatory response system that occurs due to an infection in your body can overwhelm your heart and cause the heart to have pump failure or go into shock. Thirdly, the virus itself can activate and directly cause an infection and injury to the heart muscle. And that has been, deemed myocarditis, inflammation of the heart muscle. We don't see that a lot in patients who have pre-existing heart disease. It's more seen in patients who've not had pre-existing heart disease. It's rare, so you see it in athletes or in young patients. They'll have irregular heart rhythms as a manifestation. They'll pass out on you. But those are things that we've seen in the clinical data in terms of studies. And the last piece, which is the most important piece that I want everyone to take from the call tonight, is that there are patients who do have clots. You form clots due to COVID. COVID actually forms clots in all your blood vessels, the big ones and the small ones. And what happens is that a patient who had either mild symptoms and progressed to moderate symptoms, went to the ER, went to the hospital, was discharged, not discharged on blood thinners. You go home and then you resume your activity. You're still short of breath. And then something precipitates that clot to travel to your lungs and you have a pulmonary embolism. And on autopsy or on diagnosis, they'll say, oh, he or she had a heart attack. It was a clot event that occurred. The heart attacks that occur during COVID are due to clots in the blood vessels to the heart. Those are not due to plaque buildup from all those risk factors that I mentioned before. Totally different mechanism. So the underlying key here in treatment is that when you have COVID, you need to ask if you're a candidate for a blood thinner and if you've been assessed for having a high risk for having an event related to clots in your lungs and in your heart. And there are lab values that can do that. There are imaging values that can do that with x-rays and CAT scans. And then subsequently, if they suspect that the heart has an injury, you can have an ultrasound of your heart to assess that. And that is important because I think a lot of people, and it's sad to say, both young, middle-aged, and old, have been lost because from a primary care standpoint, a specialist standpoint, and hospital standpoint, we overlooked the severity of clot formation early on in the pandemic, and the data then started coming in, and we started being more reactive in the middle to now the recent stages of the pandemic in terms of not only how we treat these patients, but also how we follow up as an outpatient. So it behooves you to see a specialist if you've had COVID, if you're having especially symptoms of chest pains, you're short of breath, you feel like your energy is not there, you're having what we call long hauler syndrome, you feel fatigued, you have insomnia. There are things that you have to follow up not only with the heart specialist, but remember, it's a lung infection. We haven't gone through a pandemic in our lifetime before. So you need to follow up with a pulmonologist, a lung specialist as well. Very, very important. And you have to note that for those who are having symptoms at home, who are reluctant to go to a hospital or to seek care, there are certain risk factors that are associated with you having a bad outcome if you have any of the underlying cardiovascular risk factors, if you've had a heart event, if you are a male versus a female. 4, if you've had an increase in your respiratory rate, you're puffing and puffing and breathing fast, or you've had a decrease in your mental status where your brain is not getting all the circulation it should get, or you've flipped a clot to your brain, that causes an altered mental status. So all those things and a low oxygen level can cause a high death rate in these patients. And so these are, severe complications of COVID that intersect, not only in terms of, you being at risk for severe complications, but also from dying from COVID. And so it's now addressing the elephant in the room. And the elephant in the room is, how do we frequently get tested for COVID? Well, we've not done a good job so far overall, especially in communities where I practice in the heart of the Delta, in terms of getting everyone access to testing, and that's something that hopefully we can address later on this call. But I think that if you have had a community that has historically been disproportionately affected and marginalized, and all COVID has done is unblind and expose those fissures in healthcare, our treatment strategy in addressing these communities should not be a one blanket method that should be applied in Madison County or Hinds County, or brought to Washington County or Bolivar County or Issaquah County and have the same model, because these counties have disproportionately been affected with the bad outcomes that not only put them at worse risk for an infection, but already they were predisposed to death at a higher rate than other counties. And so we need to take the testing to them. We need to make it available everywhere. Not special clinics or hospitals should be granted access before others. There has to be equity when it comes to that. And then we need to know that we're only left with one solution when it comes to mitigating how fast this virus is going to mutate, because it's real. Mutation is a real deal. It's an RNA virus. And the more we are resistant and hesitant about vaccines, the longer people will get affected, and this virus will live in the host of patients and replicate and mutate. So vaccinations are real. I think we need to get vaccinated. I'm speaking to you as a survivor who ended up in the ICU for 4 nights with COVID, at a very young age with no pre-existing risk condition, and had to stay at home with oxygen for a week. The analogy I use is that we're stuck in the middle of an ocean and we don't have any access to shores or any access to a safety net. None of us can swim because we all have not been in a pandemic before. And there's a rope that comes down, and it's that vaccine. We need to ask our healthcare providers when it's safe to take it, take it when we can, but also our professionals and our health officials, both local, regional, and nationally, should make sure that they are ever present and available to those who need it, because we have suffered those consequences, and that the consequence of death is something that has hurt our community. It still hurts today to hear of all the young patients and all those who had risk factors for heart and vascular disease that died prematurely because they either lacked access to testing, early treatment, or access to a vaccine. And so that's, let's do that. And thank you very much for your time. I'll come back and share some closing thoughts later on, but just wanted to thank you again for the privileged invitation. And please, 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 prevention is better than cure. I always say that in everything. And this will cost not only lives, but livelihoods. It has upended lives and livelihoods. So let's be proactive. God bless y'all.